Question 1. A critical care nurse is caring for a patient admitted with acute decompensated heart failure. The patient's assessment reveals dyspnea at rest, orthopnea, bilateral crackles, and an S3 heart sound. Which of the following hemodynamic parameters would the nurse anticipate finding? A. Decreased pulmonary artery wedge pressure, PAWP. B. Increased cardiac index, CI. C. Increased systemic vascular resistance, SVR. D. Elevated central venous pressure, CVP. Answer, D. Elevated central venous pressure, CVP. This question addresses acute decompensated heart failure, focusing on expected hemodynamic changes. The keywords dyspnea at rest, orthopnea, bilateral crackles, and S3 heart sound indicate significant fluid overload and left ventricular dysfunction, which often impacts right-sided heart pressures as well. An elevated CVP reflects increased right ventricular preload and systemic venous congestion, which is common in fluid-overloaded heart failure patients. For example, if the right ventricle is struggling, blood can back up into the vena cava and elevate CVP, contributing to peripheral edema. Remember, high CVP often signals fluid volume excess or right ventricular failure. Question 2. A patient presents to the emergency department with sudden onset of crushing chest pain radiating to the left arm, diaphoresis, and nausea. An electrocardiogram, ECG, shows ST segment elevation in leads 2, 3, and AVF. Which coronary artery is most likely occluded? A. Left main coronary artery. B. Left anterior descending artery. C. Right coronary artery. D. Circumflex artery. Answer, C. Right coronary artery. This question tests your knowledge of ECG-led localization for myocardial infarction. The keywords ST segment elevation in leads 2, 3, and AVF clearly point to an inferior wall myocardial infarction. The right coronary artery, RCA, typically supplies the inferior wall of the left ventricle, the right ventricle, and often the SA and AV nodes. Therefore, occlusion of the RCA is the most likely cause of an inferior wall MI. For instance, a patient with an inferior MI might also experience bradycardia due to SA/AV nodal involvement. Always connect specific ECG changes to the coronary artery responsible for that heart region. Question 3. A patient undergoing cardiac surgery is receiving an intravenous infusion of nitroprusside for blood pressure control. The nurse notes the patient is becoming increasingly lethargic and acidotic, with a metabolic acidosis. Which adverse effect should the nurse suspect? A. Hyperkalemia. B. Thrombocytopenia. C. Cyanide toxicity. D. Hypertensive crisis. Answer, C. Cyanide toxicity. This question focuses on a serious adverse effect of nitroprusside, a potent vasodilator. The keywords nitroprusside, increasingly lethargic, and acidotic, with a metabolic acidosis are crucial clues pointing towards cyanide toxicity. Nitroprusside metabolizes into cyanide, and if infused too rapidly or in high doses, especially in patients with renal or hepatic dysfunction, it can accumulate and cause metabolic acidosis, altered mental status, and cardiovascular collapse. A practical example is a patient developing this toxicity due to prolonged infusion durations exceeding 24 to 48 hours. Always monitor patients on nitroprusside for signs of metabolic acidosis, as this indicates a potentially life-threatening complication. Question 4. A 68-year-old patient admitted with a 2-day history of atrial fibrillation with rapid ventricular response, RVR, is experiencing hypotension and signs of heart failure. The nurse anticipates the provider will order which intervention first? A. Administer amiodarone 4 push. B. Prepare for synchronized cardioversion. C. Administer metoprolol 4. D. Obtain a 12-lead ECG immediately. Answer B. Prepare for synchronized cardioversion. This question assesses the management of unstable atrial fibrillation with rapid ventricular response. The critical keywords are atrial fibrillation with rapid ventricular response, combined with hypotension and signs of heart failure, which indicate hemodynamic instability. In hemodynamically unstable atrial fibrillation, synchronized cardioversion is the definitive first-line treatment to immediately restore sinus rhythm and improve cardiac output, as medication might not act quickly enough or might further depress cardiac function. For example, delaying cardioversion in this scenario could lead to worsening heart failure or cardiogenic shock. Remember that instability always triggers immediate, definitive interventions like cardioversion over medications. Question 5. A patient with severe aortic stenosis is scheduled for valve replacement surgery. The nurse understands that a key concern for this patient preoperatively is which of the following? A. Risk of pulmonary embolism due to hypercoagulability. B. Potential for sudden cardiac death due to fixed cardiac output. C. Exacerbation of hypertension due to increased afterload. D. Development of deep vein thrombosis from immobility. Answer B. Potential for sudden cardiac death due to fixed cardiac output. This question targets a critical understanding of the pathophysiology of severe aortic stenosis. The key concept is severe aortic stenosis, which implies a narrowed aortic valve opening. This narrowing leads to a fixed cardiac output because the left ventricle struggles to eject blood through the constricted valve, making it unable to increase output significantly with increased demand. This fixed output makes these patients highly susceptible to syncope, angina, and sudden cardiac death, especially during exertion or stress. For instance, even a small drop in preload can significantly impact cardiac output in these patients, leading to sudden decompensation. Always recognize that a fixed cardiac output is a hallmark and a major risk factor in severe aortic stenosis. Question 6. A nurse is assessing a patient with a suspected cardiac tamponade. Which of the following assessment findings is considered a classic component of Beck's triad? A. Bradycardia. B. Muffled heart sounds. C. Hypertension. D. Peripheral edema. Answer B. Muffled heart sounds. This question evaluates knowledge of cardiac tamponade and its classic signs. The core concept is cardiac tamponade, a life-threatening condition where fluid accumulates in the pericardial sac, compressing the heart. Beck's triad is the classic clinical presentation, consisting of muffled heart sounds, jugular venous distension, JVD, and hypotension. Muffled heart sounds occur because the fluid surrounding the heart dampens the sound transmission. For example, when listening to the heart, the sounds may seem distant or quiet, unlike normal strong heartbeats. Remember that these 3 signs, especially muffled heart sounds, should immediately raise suspicion for cardiac tamponade. Question 7. The nurse is monitoring a patient post-cardiac arrest who received therapeutic hypothermia. During the rewarming phase, which electrolyte imbalance is the patient at highest risk for developing? A. Hypernatremia. B. Hyperkalemia. C. Hypomagnesemia. D. Hypokalemia. Answer D. Hypokalemia. This question focuses on electrolyte management during the rewarming phase of therapeutic hypothermia. The key phrases post-cardiac arrest and rewarming phase are critical. During the cooling phase, potassium shifts into cells, leading to hypokalemia. As the patient is rewarmed, potassium shifts back out of the cells and can cause a rebound hyperkalemia, but initially during rewarming, the cellular uptake might persist, making hypokalemia a continued risk, or, more commonly, as the metabolic rate increases, potassium can rapidly shift into cells, exacerbated by insulin release or bicarbonate administration, leading to hypokalemia. For instance, the re-establishment of cellular pump function during rewarming can rapidly drive potassium back into cells. It is essential to closely monitor serum potassium levels and supplement as needed during this vulnerable period. Question 8. A patient with a history of heart failure is prescribed furosemide 40 mg 4 daily. The nurse identifies which of the following as a priority assessment before administering this medication? A. Blood glucose level. B. Serum potassium level. C. Liver function tests. D. White blood cell count. Answer, B. Serum potassium level. This question tests the understanding of safe diuretic administration, specifically loop diuretics like furosemide. The key is furosemide 40 mg 4 daily, which is a potent loop diuretic used for heart failure. Furosemide causes significant excretion of electrolytes, particularly potassium, through its action on the loop of Henle. Therefore, monitoring serum potassium levels is crucial to prevent potentially dangerous hypokalemia, which can lead to cardiac arrhythmias. For example, a patient with a critically low potassium could experience life-threatening ventricular tachycardia. Always prioritize checking potassium before administering furosemide to prevent serious cardiac complications. Question 9. A patient is admitted with symptoms of an acute ST elevation myocardial infarction, STEMI. Which of the following is the most appropriate initial nursing intervention upon arrival to the emergency department? A. Administer intravenous unfractionated heparin. B. Prepare for percutaneous coronary intervention, PCI. C. Administer aspirin and nitroglycerin. D. Obtain a detailed medical history. Answer, C. Administer aspirin and nitroglycerin. This question assesses the immediate priorities for a patient presenting with STEMI. The critical keywords are acute ST elevation myocardial infarction, STEMI, and initial nursing intervention upon arrival. While preparing for PCI is the definitive treatment, and heparin may be given, immediate administration of aspirin to prevent further platelet aggregation, and nitroglycerin to reduce pain, dilate coronary arteries, and reduce preload are foundational first steps in managing STEMI, often given even before a 12-lead ECG is finalized, if clinically indicated. For example, aspirin given promptly can significantly reduce mortality in MI patients. Remember the mononymonic, morphine, oxygen, nitroglycerin, aspirin, as general initial care, with aspirin and nitroglycerin being crucial early interventions for chest pain and clot prevention. Question 10. The nurse is caring for a patient with an intra-aortic balloon pump, IABP. Which assessment finding indicates a potential complication related to the IABP insertion site? A. Diminished pedal pulses on the ipsilateral leg. B. Increased urine output. C. Stable blood pressure readings. D. Absence of a palpable thrill at the insertion site. Answer. A. Diminished pedal pulses on the ipsilateral leg. This question addresses a critical complication associated with intra-aortic balloon pump, IABP, therapy. The keyword IABP insertion site points to vascular complications related to the femoral artery insertion. The most significant complication is limb ischemia, caused by the balloon catheter obstructing blood flow to the extremity. Diminished or absent pedal pulses on the same leg as the IABP insertion, ipsilateral leg, are a direct sign of impaired circulation and require immediate intervention. For example, a patient might complain of leg pain, coolness, or paresthesias in that leg. Always assess peripheral circulation meticulously in the limb where the IABP is inserted to detect early signs of ischemia. Question 11. A patient with severe chronic heart failure develops acute shortness of breath and frothy pink sputum. The nurse administers oxygen and prepares to give intravenous diuretics. What is the primary goal of this immediate intervention? A. To decrease cardiac contractility. B. To reduce systemic vascular resistance. C. To lower preload. D. To increase afterload. Answer, C. To lower preload. This question focuses on the acute management of pulmonary edema secondary to heart failure. The keywords acute shortness of breath, frothy pink sputum, and intravenous diuretics strongly indicate acute pulmonary edema due to fluid overload. Diuretics, like furosemide, primarily work by promoting fluid excretion, which directly reduces the circulating blood volume returning to the heart. This reduction in venous return effectively lowers preload, decreasing the volume of blood the heart has to pump and relieving pulmonary congestion. For example, by decreasing the fluid in the lungs, the patient's breathing will improve. Remember that in fluid overload conditions, reducing preload is a fundamental strategy to improve cardiac function and respiratory status. Question 12. A patient with a history of hypertension is admitted with a blood pressure of 220/120 mmHg, headache, and visual changes. The nurse anticipates the administration of an intravenous antihypertensive agent to gradually lower the blood pressure. What is the primary goal for the initial reduction in mean arterial pressure, MAP, in this emergent situation? A. Reduce MAP by 50% within the first hour. B. Reduce MAP by no more than 10 to 20% in the first hour. C. Reduce MAP to below 100 mm of mercury within 30 minutes. D. Reduce MAP to normal range, e.g., 70 to 100 mm of mercury, immediately. Answer, B. Reduce MAP by no more than 10 to 20% in the first hour. This question addresses the critical management of a hypertensive emergency. The key phrases are blood pressure of 220/120 mmHg, headache, and visual changes, indicating target organ damage, and gradually lower the blood pressure. In a hypertensive emergency, the primary goal is a controlled and gradual reduction in MAP to prevent hypoperfusion of vital organs. Reducing MAP too quickly or too drastically can lead to ischemic complications, such as stroke or myocardial infarction. For example, a patient with chronic hypertension needs time for their cerebral autoregulation to adjust to lower pressures. Therefore, a cautious reduction of MAP by no more than 10 to 20% in the first hour is recommended to ensure patient safety. Question 13. A patient develops ventricular tachycardia, VT, with a palpable pulse, but is hypotensive and confused. Which intervention should the nurse anticipate immediately? A. Administer intravenous adenosine. B. Prepare for synchronized cardioversion. C. Administer intravenous amiodarone. D. Initiate immediate defibrillation. Answer, B. Prepare for synchronized cardioversion. This question tests the management of unstable ventricular tachycardia. The crucial keywords are ventricular tachycardia, VT, with a palpable pulse combined with hypotensive and confused, which indicate the patient is hemodynamically unstable despite having a pulse. When a patient with VT has a pulse but is unstable, e.g., hypotension, altered mental status, signs of shock, acute heart failure, ischemic chest pain. Synchronized cardioversion is the immediate treatment of choice to convert the rhythm and stabilize the patient. For instance, waiting for medications like amiodarone to take effect could lead to further deterioration. Remember that instability with a pulse usually calls for synchronized cardioversion, whereas pulseless VT requires defibrillation. Question 14. A patient is admitted with a diagnosis of unstable angina. The nurse understands that this condition is characterized by which of the following? A. Chest pain that is relieved by rest and nitroglycerin. B. Non-ST elevation on the electrocardiogram, ECG, and positive cardiac biomarkers. C. Chest pain that occurs at rest or with minimal exertion and is not relieved by nitroglycerin. D. ST segment elevation on the ECG and elevated cardiac biomarkers. Answer: C. Chest pain that occurs at rest or with minimal exertion and is not relieved by nitroglycerin. This question focuses on the defining characteristics of unstable angina. The key phrase unstable angina implies a more serious form of acute coronary syndrome compared to stable angina. Unlike stable angina, which is predictably relieved by rest and nitroglycerin, unstable angina is characterized by new-onset chest pain, pain that is increasing in frequency or severity, or pain that occurs at rest or with minimal exertion and is not readily relieved by nitroglycerin. For example, a patient might report their usual angina becoming much worse or occurring without any trigger. It's crucial to recognize this difference as unstable angina indicates a higher risk for myocardial infarction. Question 15. The nurse is caring for a patient with an anterior myocardial infarction who develops an S4 heart sound. The nurse understands that an S4 heart sound is indicative of which pathological change? A. Right ventricular failure. B. Left ventricular systolic dysfunction. C. Left ventricular diastolic dysfunction. D. Mitral valve regurgitation. Answer: C. Left ventricular diastolic dysfunction. This question assesses the significance of an S4 heart sound in the context of cardiac pathology. The keyword S4 heart sound is the primary clue. An S4, often described as an atrial gallop, occurs just before S1, representing the sound of atrial contraction against a stiff, non-compliant ventricle. This stiffness is characteristic of left ventricular diastolic dysfunction, where the ventricle struggles to relax and fill properly. For example, in an anterior MI, the damaged left ventricle may become stiff and non-compliant, leading to an S4 sound as the atria try to force blood into it. Therefore, an S4 often signals impaired ventricular relaxation or increased ventricular stiffness. Question 16. A patient with severe heart failure is being assessed for eligibility for a left ventricular assist device, LVAD. The nurse understands that the primary purpose of an LVAD is to A. Replace the native left ventricle entirely. B. Supplement the pumping function of the right ventricle. C. Enhance the pumping function of the left ventricle. D. Act as a bridge to pulmonary transplantation. Answer: C. Enhance the pumping function of the left ventricle. This question examines the purpose and function of a left ventricular assist device, LVAD. The key phrase left ventricular assist device, LVAD, itself highlights its primary role. An LVAD is a mechanical pump implanted into the chest that helps the weakened left ventricle pump blood from the left ventricle to the aorta, thereby improving systemic circulation. It does not replace the native left ventricle but rather supplements its function. For example, an LVAD can dramatically improve a patient's quality of life and prolong survival while they await a heart transplant or as destination therapy. Remember that LVADs are designed to assist the left ventricle, not replace it or affect the right ventricle directly. Question 17. A nurse is assessing a patient with a newly inserted permanent pacemaker. Which finding should the nurse immediately report to the provider? A. Intermittent hiccups. B. Slight soreness at the insertion site. C. Heart rate consistently 5 beats higher than the programmed rate. D. Occasional skipped beats noted on the monitor. Answer: A. Intermittent hiccups. This question tests recognition of a serious complication following pacemaker insertion. The keywords newly inserted permanent pacemaker and intermittent hiccups are crucial. Intermittent hiccups or persistent twitching can indicate diaphragmatic pacing, meaning the pacemaker lead has perforated the ventricle and is stimulating the diaphragm. This complication requires immediate evaluation and possible repositioning of the lead. For example, if the patient reports feeling a regular thump in their abdomen with each heartbeat, it suggests diaphragmatic stimulation. Always be vigilant for signs of lead dislodgement or perforation after pacemaker placement. Question 18. A patient is on continuous cardiac monitoring and the nurse observes a rhythm of ventricular fibrillation, VF. The patient is unresponsive and pulseless. What is the nurse's immediate priority action? A. Administer 4-epinephrine. B. Prepare for synchronized cardioversion. C. Initiate chest compressions and call for defibrillator. D. Obtain a 12-lead ECG. Answer: C. Initiate chest compressions and call for defibrillator. This question tests the immediate management of a life-threatening arrhythmia. The keywords ventricular fibrillation, VF, unresponsive, and pulseless indicate a cardiac arrest situation. In VF, the heart's electrical activity is chaotic and ineffective, leading to no cardiac output. The immediate priority is to start high-quality chest compressions and initiate defibrillation as quickly as possible, as defibrillation is the only definitive treatment to terminate VF. For example, every minute delay in defibrillation significantly reduces the chance of survival. Remember, time is myocardial tissue, and immediate action is paramount in VF. Question 19. A patient with a history of intravenous drug use is admitted with fever, new-onset murmur, and splinter hemorrhages. The nurse suspects infective endocarditis. Which diagnostic test is most crucial to confirm the diagnosis? A. Chest X-ray. B. Electrocardiogram, ECG. C. Blood cultures. D. Echocardiogram. Answer: C. Blood cultures. This question focuses on the diagnostic workup for infective endocarditis. The keywords intravenous drug use, fever, new-onset murmur, and splinter hemorrhages are classic signs of infective endocarditis. While an echocardiogram helps visualize vegetations, and an ECG may show conduction abnormalities, blood cultures are absolutely crucial for identifying the causative microorganism. Positive blood cultures, along with clinical criteria, are essential for definitive diagnosis and guiding antibiotic therapy. For instance, without identifying the specific pathogen, targeted treatment cannot be initiated. Always prioritize obtaining multiple sets of blood cultures from different sites before starting antibiotics if infective endocarditis is suspected. Question 20. The nurse is caring for a patient who underwent a percutaneous coronary intervention, PCI, with stent placement. 6 hours post-procedure, the patient reports new-onset acute back pain. What is the nurse's priority action? A. Administer a pain reliever as ordered. B. Reassure the patient that back pain is common after bed rest. C. Assess for signs of retroperitoneal hemorrhage. D. Encourage deep breathing and coughing. Answer C. Assess for signs of retroperitoneal hemorrhage. This question addresses a serious complication following a percutaneous coronary intervention, PCI. The key phrases PCI with stent placement and new onset acute back pain are critical clues. Acute back pain after PCI, especially if the femoral artery was accessed, can be a sign of retroperitoneal hemorrhage. This occurs when blood leaks from the access site into the retroperitoneal space and can be life-threatening. For example, along with back pain, the patient may also show signs of hypovolemic shock like hypotension and tachycardia. Always suspect retroperitoneal hemorrhage and perform a thorough assessment for bleeding and hemodynamic instability when a patient complains of back pain post-PCI. Question 21. A patient with chronic stable angina is prescribed sublingual nitroglycerin. The nurse educates the patient on proper administration. Which instruction is most important? A. Take 1 tablet every 30 minutes until pain subsides. B. Store the tablets in a clear, plastic container for easy access. C. Place 1 tablet under the tongue at the onset of chest pain. D. Take 2 tablets at once for severe pain. Answer C. Place 1 tablet under the tongue at the onset of chest pain. This question tests knowledge of correct sublingual nitroglycerin administration. The concept is safe and effective use of sublingual nitroglycerin for chronic stable angina. The most important instruction is to place 1 tablet under the tongue at the onset of chest pain. This allows for rapid absorption directly into the bloodstream for quick relief of angina. For instance, if chest pain persists after 5 minutes, the patient should call 911 and may take a second dose, followed by a third if necessary while awaiting emergency medical services. Always emphasize that sublingual nitroglycerin is for acute chest pain and should be taken at the first sign of discomfort. Question 22. A critical care nurse is managing a patient experiencing cardiogenic shock. Which of the following medications would be most appropriate to administer to improve myocardial contractility? A. Dopamine. B. Nicardipine. C. Furosemide. D. Enalapril. Answer A. Dopamine. This question focuses on pharmacological management in cardiogenic shock. The keywords cardiogenic shock and improve myocardial contractility indicate the need for an inotropic agent. Dopamine, a vasopressor with dose-dependent effects, acts on beta-1 adrenergic receptors at moderate doses to increase myocardial contractility and heart rate, thereby improving cardiac output. For example, a patient in cardiogenic shock needs their heart to pump more effectively to perfuse vital organs. Remember that inotropes like dopamine, dobutamine, and milrinone are used to strengthen heart contractions in conditions of severe heart pump failure. Question 23. A patient with a new diagnosis of dilated cardiomyopathy is being discharged. The nurse provides education on lifestyle modifications. Which statement indicates the patient understands the teaching? A. I should limit my fluid intake to 3 to 4 liters per day. B. I will monitor my weight daily and report any gain of more than 2 pounds in a day. C. I can stop taking my medications once I feel better. D. I should increase my sodium intake to help maintain blood pressure. Answer B. I will monitor my weight daily and report any gain of more than 2 pounds in a day. This question assesses understanding of discharge education for a patient with dilated cardiomyopathy, a form of heart failure. The crucial concept is managing heart failure symptoms and preventing exacerbations. Daily weight monitoring and reporting sudden gains, typically greater than 2 to 3 pounds in 24 hours or 5 pounds in a week, is a critical indicator of fluid retention, which is a hallmark of worsening heart failure. For instance, a rapid weight gain often means the heart is struggling to pump fluid effectively, leading to fluid overload. Always emphasize daily weight checks as an early warning sign for decompensation in heart failure patients. Question 24. A patient in the ICU is on continuous vasopressor infusion, and the nurse notes blanching and coolness to the skin distal to the peripheral intravenous site. What is the nurse's initial action? A. Increase the rate of the vasopressor infusion. B. Administer an intravenous bolus of normal saline. C. Discontinue the peripheral and elevate the extremity. D. Prepare to administer phentolamine into the extravasated area. Answer: C. Discontinue the peripheral and elevate the extremity. This question addresses a critical complication of vasopressor administration. The keywords continuous vasopressor infusion, blanching and coolness to the skin distal to the peripheral site indicate probable extravasation, where the medication has leaked out of the vein into surrounding tissue. The initial priority is to stop the infusion and remove the compromised line to prevent further tissue damage. For example, leaving the vasopressor infusing in extravasated tissue can cause severe vasoconstriction and necrosis. After discontinuing the elevating the extremity can help reduce swelling, and then phentolamine may be considered to counteract the vasoconstriction. Question 25. The nurse is monitoring a patient recovering from a cardiac catheterization. Which finding requires immediate intervention? A. Mild oozing of blood at the sheath insertion site. B. Distal pulse in the affected extremity is slightly weaker than the unaffected. C. Occasional premature ventricular contractions, PVCs, on the cardiac monitor. D. Patient complains of numbness and tingling in the affected extremity. Answer: D. Patient complains of numbness and tingling in the affected extremity. This question focuses on critical complications after a cardiac catheterization. The key is recovering from a cardiac catheterization and numbness and tingling in the affected extremity. Numbness and tingling, combined with potentially a weaker pulse, though the numbness is more acute here, are cardinal signs of arterial occlusion or nerve compression, indicating impaired circulation or nerve damage to the limb distal to the insertion site. This could be due to thrombus formation, hematoma, or dissection at the access site. For example, if circulation is severely compromised, the patient could be at risk for limb ischemia. Always assess neurovascular status meticulously post-catheterization and report any changes promptly.